that in the days of old, even 10 years ago, when other specialties were dealing with this, the paradigm was that, your conservative therapy until you get in dire straits.
Or like, your legs falling off.
And we really have not, held that to be true. We really want the patients to feel better. And if they are not doing well in medical therapy, we will offer them other options that are available, and we'll offer them early. Because quite frankly, if you have a diabetic patient who's overweight and has high cholesterol and high blood pressure, if they are not able to walk and exercise and help those other issues, they're going to get worse with time.
That's right. I mean, on one hand, you tell them to exercise, on the other hand, they're unable to exercise. And then what are you going to tell them?
Exactly.
So it looks like we have one more caller, Mike from Lafayette on line 1. Mike, go ahead. You're live.
I wanted to know if restless leg syndrome is related to PAD. Is that the same thing, or?
Okay, well, we'll try to talk about that. Is that all your question, or do you have anything else to extend that?
No, sir. I just heard the term, and I'm curious if it's related.
Okay. Nick, you want to say a couple of words about that, restless leg syndrome?
Restless leg syndrome, usually is not related to vascular disease or artery disease or venous disease. It's more of a nerve muscle disorder that just causes the muscles to twitch, and basically it's kind of little short-lived spasms that kind of move the leg around. However, there are episodes where there is cramping or lack of blood flow to the muscles of the leg, at rest, especially at night, that may be due to artery blockage, and those are much rarer, but certainly it is a possibility. But restless leg usually is not related to PAD.
Well, I want to just kind of shift gears and probably spend a few minutes here to ask John about his passions about structural heart disease and how he got interested in it, and what is structural heart disease, and what should the audience kind of understand it to be, and why should they be bothered about it?
Sure. So, when we talk about structural heart disease, what we're talking about is the some malformation of the heart with birth in certain cases. So, for example, holes in the heart, and when somebody's been told that they are a blue baby or they have a blue baby, very often that's related to a persistent hole that allows a mixing of oxygenated, unoxygenated blood. But also it can be acquired. So when we talk about structural heart disease that is acquired, very often we're talking about valves that have degenerated. So, the valves are the doors in the heart keeping the blood moving all in the one direction. And either through age or through illness or through sometimes infection, people can acquire damage to these valves so that when they close, they don't close all the way and blood goes the wrong direction, or perhaps they don't open all the way and blood has a hard time passing from one chamber to the next. Another potential structural heart disease is a ballooning or stretching of the left ventricle. So for example, somebody who's had a large heart attack and they get a large scar on the sort of tip end of their heart, that also is really considered structural heart disease because it results in the change in the way that heart can function and the way the heart can squeeze. And there are steps that can be taken surgically to repair each one of these problems. Where we are today, however, is we are moving into an era, and why it's my passion, into an era where we can fix a lot of these problems percutaneously from a catheter, just like a heart cath, where we run the tube up to the heart and we advance a device and we can fix this structural problem without having to have open heart surgery necessarily. So for example, one of the new products that'll hopefully be out in relatively near future is the artificial aortic valve. This is something that every cardiologist is waiting for impatiently because this means that for certain people who otherwise couldn't have surgery to repair the valve and therefore a very short lifespan, we may have a real solution for them by advancing a new valve through a catheter to where the old valve is and being able to repair it that way. For myself, I've been the last several years focusing specifically on the holes that separate the top two chambers of the heart that allow that mixing of blood. We have a very simple device that advances through the catheter that will seal that hole, much like a button. So, these are the things that as cardiology advances, the real new frontier is how to fix these things and how to improve the tools to allow us to fix these things efficiently and safely.
That's fantastic. We'll take one more call here from Lois from Opelousas, again on line 1. Go ahead, Lois. Are you online?
Yeah,
Go ahead, dear.
yeah. I have a question for Dr. Verena. I have a stent already in my right leg,
Okay.
but my right leg is giving me trouble. I can't hardly walk. It hurts from my calf on down. It stiffens up on me. I went to the emergency room. They took an ultrasound. They said it came out normal, but that leg is giving me the blues. And I was wondering, a person with a stent put in the right leg, could it also be a PAD problem? Is that possible?
That's a very good question. Here, looks like the audience, here Lois is a bit more advanced here. She does have a diagnosis of peripheral arterial disease already. Looks like either some of us, one of us, or might have put a stent in the leg artery, and she still continues to have pain in the leg artery. So it could either mean one or two things. It could be that she could potentially have an ultrasound in the emergency room, may not be as complete a study. So I think we had to revisit in our records, see how long has it been since she had a thorough investigation, maybe do a physical examination, see whether she has blockages higher or lower than the stents, and see the flow patterns of this ultrasound. And certainly the smaller arteries, as we all know, below the knees, are somewhat hard to visualize by arterial ultrasound. So an ankle brachial index, or even revisiting a prior arteriogram, if it is years before or if it is several months before, depending on her risk profile, if she's an active smoker, or if she's a diabetic, or if she's taking or not taking her medicines. A lot of questions have to be thought about before we really kind of say, oh, well, it's not a vascular problem. On the other hand, when we look at all these aspects, if they're all fine, we then move on to other aspects like peripheral neuropathy, or just basically inflammation of the nerves, which could happen frequently in patients with peripheral arterial disease, and especially in diabetics as well. And the other types of neuropathies, mainly radiculopathies as we call them, compression of the larger nerves emerging from the spine and just radiating down. So they have not so subtle variation in their characteristics. So we can look at all those things, but definitely stent looking good in the emergency room is a good sign to begin with.
Good sign.
I think, but if the stent is blocked, it's worse off than stent being open, but that in itself doesn't end the whole problem here. We probably need to dig a little deeper. And with that said, I'll invite Lois to my office or my partner's office to look at that problem. And we have one more caller, Debbie from Lafayette on line 2. Debbie, go ahead, you're live.
Yes, sir. I have a question. My question is for you is, I'd like to know is when I'm sleeping at night, you get really bad, like jolly horses all in through the back of my legs and everything. And I wake up, the next morning I wake up, my legs are hurting, and I have a bad headache from all of this. Can you tell me what's the cause of that?
Okay. Well, we'll try to, John or Nick, please, if you feel free to just answer. Charlie horses, it looks like she's a younger lady, or depending on the age, and hurts all night and doesn't get enough rest, wakes up with a headache and leg pain.
Sure. Usually Charlie horses are not related to PAD or vein problems. More than likely they're related to salt issues in the blood and maybe hydration issues as well. More than likely. And rarely in some patients, especially young patients who are obese, sometimes sleep apnea can have, some similar effects and can also, cause headaches as well. But, those are kind of, the
broad
two more major issues.
And with the heat this summer,
exactly.
dehydration.
She needs to make sure that she's well hydrated, make sure her electrolytes are okay, drink plenty of fluids.
Now, I don't know what kind of remedies you guys have here in Louisiana, but us having come from North Carolina, we had a whole host of home remedies that we heard, everything from putting a bar of soap in the bed to mustard. It was everything we've heard.
Exactly. But at least it's not anything major that pertains to our discussion here with respect to advanced peripheral arterial disease. And of course, Charlie horses, as she classically described it, can also be confused in a patient with appropriate risk factor profile.
Sure.
You do need to worry a little bit whether this is in the arena of peripheral arterial disease, or PAD as we kept on referring to. And John, that about structural heart disease, and we are all, as we too have some amount of interest probably looking at the extent of this whole PFO and the atrial septal defect issues. While ASDs and these congenital heart problems are not as prevalent in adults in this country, probably PFOs are definitely far more. And the other valve problems you kept talking about, like the sclerotic or the hardened aortic valve, which doesn't allow enough blood to get, which seems like a much bigger problem in our aging kind of a baby boomer group of patients in our country here.
Yeah, well, it really is, and you know, one of the problems, you know, with valve repair is timing. So very often what happens is a 70-year-old person comes in and they've got mild aortic stenosis, meaning there's some calcification. The door opens, but maybe not quite as well as it should, but plenty of blood's able to leave the heart. And we follow that routinely with ultrasound to make sure that it's not progressive. We follow the patient for symptoms, being chest pain or feeling like they're going to pass out, sometimes shortness of breath. And despite all our efforts, you know, very often these things can progress and even get to a point where now all of a sudden, either because of age or because of degree of dysfunction from the heart, they're no longer a very good surgical candidate. So it's one of those things that really requires a lot of attention. You know, the patient needs frequent follow-ups and then these routine echoes based on their symptoms and how bad the valve is, you know, and then we try to time it, because when you put in an artificial valve, it doesn't last forever. You know, the valve itself, you know, whether it's mechanical or tissue, has sort of a finite lifespan. If we put it in too soon, then the patient may be looking at a redo valve. If we put it in or wait too late, then maybe the patient...
Too much helpful.
That's right, it's not very helpful. So, you know, by developing these percutaneous valves, if for example, a person did go undiagnosed, and actually it happens, you know, not too infrequently, then you still potentially have an option to fix that patient and have them functional. You know, the problem is as you become a cardiac cripple, if you don't have enough blood flow leaving the heart, you can't function. You get short of breath, you can't walk, you can't, you know, participate in your daily activities. So, you know, this really could be a game changer for many people.
Absolutely. This just seems like we are coming with that discussion. We are coming to the last minute of this thing. Nick, you have any closing remarks as to what your thoughts are about?
No, I just think these are very exciting times, both in coronary disease, peripheral arterial disease, and structural heart disease. We have a number of new modalities that are coming out, new therapies that are coming out that will benefit our patients, even the high-risk patients that were not candidates before. And you know, we're happy as a group, CIS, to bring these to this community.
Absolutely. Again, I'm really happy to have both Dr. Patterson and Dr. Kavros taking time to get down and sit in this show and talk to the audience and basically answer any potential questions about cardiovascular disease. And both Dr. Patterson and Dr. Kavros are practicing at Lafayette General, but we all will be, I of course practice, as most of our audience know, practice at Appaloosas General, but we'll all be actively sharing our knowledge base as well as sharing patients and services in future. And I thank all our audience for tuning in and watching this show. We will bring this show every month on the second Tuesday from the heart, and we had a very lively discussion, and thank you and good night.